So good evening, everyone. Once again, I welcome you all to the session called Dare to Bear. We have our chief instructor here with us, Dr. Surya Gupta. So sir, I request you to please take over and start the presentation with our first speaker.
Yes, thank you. And I would like to welcome all the panelists and the audience. We can't see the audience physically, so I don't know how many people are there at all. So welcome to our session. If you have been following us at various conferences, what we do is instead of showing our bravado, what we try to show is the mistakes we have made, and so that you don't make the same mistake that we have made. So just to avoid that, this is a session which we call Dare to Bear. We are bearing our souls. Please don't laugh at us, but try to take the message which we have learned the hard way. And hopefully you won't have to go through that nightmare again. So the first speaker, I invite Dr. Professor Amar Agarwal. Now, he doesn't need any introduction. And in fact, I always keep him in my session so that my IC gets accepted in the first place. He is one of the priority names in our session. So, sir, if you can start anytime, sir.
Sure.
Sir, one more thing. How much time are we giving to each presenter? So accordingly,
it's about 8 minutes, but we already have a lot of time with us. So if they go ahead or even for a minute or so, it's fine.
So you want me to put the timer, or you'll continue?
Yeah, you can put the timer for 8 minutes.
For 8 minutes.
Then we take it from there.
Okay.
Let me see if my video is coming.
Yes, sir, it's coming.
Yes, sir.
One minute. Yeah, okay. So first of all, before I start the video, I'd like to first of all congratulate Dr. Surya, because basically I think what he's done is so much of work in the system here, you know, overall done so much of work in not only, I think, teaching so many people, but also, you know, educating everyone on the story here. And I think when you're trying to show complications of yours, I think it's a tricky game, because I think, you know, as things stand, it takes time to show various complications of everyone in the world, what they are doing, things like that. So let's see now. I'll show you the case which I wanted to show you about. He asked me to show you a crazy case like Dare to Bear. So if you see this case here, pseudophakic bullous keratopathy is there with an anterior chamber IOL. Now, these are very complicated cases. The problem with these anterior chamber IOLs are pretty bad. So you notice here what I'm doing here is I made my scleral flaps. My next step is I'm making a scleral tunnel incision. Now I'm taking off this hypertrophied epithelium there. And once I take it off, you see, I can see a better view. And I'm seeing an anterior chamber IOL there. Now, the flaps, one of the problems is they should be 180 degrees apart. You notice I did not have them 180 degrees apart. So at that stage, what I have done now is adjusted it so that I've got it exactly 180 degrees apart. I've gone in with a 22 gauge sclerotomy and then doing a vitrectomy. Now, in such cases which come to me from outside or somewhere, I do not know what is inside the eye. So I always go in and do a posterior vitrectomy, because the surgeon might have left a nucleus behind, an IOL behind, something might be inside. Once I've done that, make my scleral tunnel incision. Now the question is to remove the IOL. So you can see now I'm taking it out very slowly. The problem with these type of IOLs are they get locked onto the iris, and it's very tough to remove. So you have to be careful. Invariably, sometimes they break. As you can see, it's broken here. But I've taken off one loop, then the second haptic. Now still some haptics are still inside. So now you can see the third one coming out. The fourth one is still stuck onto the iris through an iridectomy. Now you got to be careful that we don't produce a bleed. So I'm trying to remove it very slowly there. And you can see they're removed there. Once I've removed it, you can see slight bleeding is occurring, but it has been stopped. Now, once I have removed the anterior chamber IOL, my next step is to do the vitrectomy, which I've done just now, and then go in for a glued IOL. Now, you can see, since I already have a large incision, all I need to do is just extend. I can use it like a non-foldable IOL. Any IOL, 3-piece can be implanted, catch one haptic, externalize. Now, watch the second one. Transfer the haptic from one hand to another. This is the handshake technique. You can see I've transferred it from one hand to the other. Once that's done, I go back in through the sclerotomy, catch that haptic, and externalize the second haptic. Now notice carefully, you will see here the amount of haptic externalized is a lot. That is a very important issue which we need to understand totally. Then you take a 26 gauge needle, and you can see I'm created the Gabor-Charier's pocket and tucked it inside. Same thing I'm doing on the other side. Once I have both haptics tucked. So now what have I done? I've done the anterior chamber lens explantation. 2, I've done the vitrectomy. 3, I've done a glued IOL. But I have to do a pupilloplasty, though the pupil is small, because what will happen is if there is some closed angle, it will become open angle. So we do the single pass 4-throw pupillasty. For those who are watching, remember, take a 9-0 or 10-0 Prolene, go straight through the clear cornea and iris. Remember, you do not need a paracentesis on the one side. On the other side, you have a paracentesis. Pass a 30 gauge needle through the paracentesis, through iris, railroad the two, bring the needle out. Now bring this loop out. This is the single pass. Now all you do is remember the number 4, pass it 4 times, and that is game, set, and match. Once you have done that, you can do as much as you want. So notice carefully now, from one side I'm going in. Remember, you do not need a paracentesis on both sides, only on one side. On this side you don't need. On this side you need. So now you have brought the needle out. Now you bring the loop out. You can see I'm using an endometer from outside to see better. Once that is out, now you pass it 4 times and you will be done. Now what does this help us in? 1, the air will remain in the anterior chamber. 2, a closed angle will become open angle. And 3, I have created a pinhole pupil. So any astigmatism problem gets solved automatically. So remember that even if you have a case like this, just do this pinhole pupillasty and the whole problem gets solved. Now we take the endothelium facing us, as you can see, inject a bubble. Now you see here the bubble there, that's a type 1 bubble. Now question comes, why am I doing a PDEC? Why I never do Dissection? Why do I never do DMEC? And in Agarwal Center, we do about 100 keratoplasties a month. So the reason is simple. Remember, in Dissection, you're taking about 80 micron, 100 micron, whatever it is, but it is too thick, which is not needed. In DMEC, you're taking 15 micron, which is fantastic. But there is one problem in DMEC. The biggest problem in DMEC is you cannot take off the endothelium and desmase till the donor is 50 years. That means effectively you're taking donors above 50 years, which in PDEC it's 25 microns, but I'm using only young donors, 20-year-old, 18-year-old, 15-year-old donors. Now we have created this bubble, make a knife entry into it, inject trypan blue, stain it, and you have your PDEC graft ready to inject. Now, one more thing advantage in PDEC, which for us there is no comparison between PDEC and the other procedures, is you can manipulate this tissue because the Dua's layer gives you a splinting. Here you see we are doing an air pump filled PDEC in which air pump is continuously infusing air inside, and you can notice I've got fluid from the back with a trocar and from the front and anterior chamber like a trocar ACM. So both sides is working. Take the PDEC graft, take any injector, inject it inside. Now all I do is unroll it just like how you'll do DMEC. These are 25 micron grafts, inject the air. But look at the beauty of this procedure in PDEC is I can manipulate. In DMEC, it will tear. See the movement? I can move it wherever I want. Nothing will happen to that graft. That is one of the another reasons why we only do PDECs. We never do any other procedure. Apply the fibrin glue, seal everything down. The final question comes, how did this patient behave? That's the end of the result. So let's see how this patient behaved at the end of the day. This is the patient at the end, how he's looking. Now look 2 weeks post-op. Compare it to the pre-op picture. 1 month post-op, 2 months post-op. And now you can see the final picture, 3 months post-op, and end of the day, you'll see the 9-month post-op 2020 and compare it to the 6/6 vision compared to the pre-op. Thank you very much. I'll stop sharing this screen now. So I'd like to thank again Dr. Surya for inviting me for his lovely course on this. I thought I'll show you this particular case, which is very complex. Surya, up to you.
Mute. Surya, you are mute, unmute.
So I always thought that the only thing you can do with an eye is replace the lens with a artificial lens. So many things can be done, and that too successfully. Most of the time I rip off the Dua's layer is when I'm doing a phaco. So it's most of the time it's inadvertent, but excellent surgery, sir. Thank you, sir, for the lovely presentation. I believe Dr. Liu has joined us. Sir, are you ready for your keynote address?
Hello. Yes, I am. Do you have my slides? Can you project for me, or shall I project from here?
You have to do it yourself, sir. We don't have your slides.
Okay, okay, fine. I've actually signed in twice, so.
You're ready to go ahead now, or do you want?
Yes.
Okay.
Yes, ready to go ahead.
Yes, sir. Dr. Liu is a multi-award-winning consultant ophthalmic surgeon of world renown. He has over 30 years of experience, and he is one of the pioneers of DMEC corneal transplant surgery in UK, immediately and sequential bilateral cataract surgery, etc. So he needs no introduction. He has multiple international presentations, and he has graced us with a keynote talk. So, sir, whenever you're ready.
Thank you. Right. Today, I am just presenting two very, very simple things. It's the risk of endophthalmitis when patients wear face masks, and also when they put moisturizer or skin cream on their face. So I will just take you through a few slides to open a discussion and to bring this to your awareness. I don't have any financial interest. So let's firstly look at the hazards of patients wearing face masks. As you have all experienced as ophthalmologists, when we're examining patients in clinic, their glasses steam up when they are reading the visual testing chart. So what about that? Well, I think what we might do is ask them to hold their breath when their glasses go on, and then work out which is the lowest line they can read, and just say that rather than talking and going from the very top of the chart. We also have difficulties with our 90 or 78 diopter lens steaming up. And also when they're having their OCT scans, the OCT lenses can also steam up. And of course, with the steaming up, we're also contaminating all these lenses. Now, when we're giving intraocular injections, the breath, which is from the patient's pharynx, is now directing to the operating field. So we have to be careful. And same for cataract and other intraocular surgery, that the patient's breath with all the bugs can be misdirected to the operative field. Finally, I think some people are aware, and most people are not aware, that post-operatively, let's say we have done a phaco and the wound is self-sealing. However, it is not completely sealed in the initial period. So if we ask them to put a mask on straight away, there is also a theoretically higher risk of endophthalmitis. If you look at different masks, they will have different construction. Now, in the olden days in the UK, we had these straps. And what we can do is to tighten the upper straps a lot more and loosen the lower ones so that the breath can come from the side or underneath the chin rather than up to the eye. You will also see that in good quality masks, there is a strong aluminum strip here, which you can really shape to the nose very nicely, and that reduces steaming. And in a really high quality mask, again, you have a strip of foam here, which also reduces steaming. However, these masks are difficult to come by, and mostly we're wearing masks which have ear loops. You can see ear loops. So the possible solutions with regards to masks during the pandemic, well, higher quality masks if you have them. And then the other possibility is taping with a micropore so that the breath necessarily comes through the side and from underneath. And also we have the option of holding breath momentarily during fundal examination or when testing visual acuity. Now, I think in the UK now, we would say for intraocular injections and intraocular surgery, we say no mask for the patient during these procedures. And for post-op, it would be an idea, probably no mask for a few days or possibly up to a week. Say if you've done phaco surgery and the eye is patched with a gel net and an iPad, then they can still wear a mask until the following day when they remove the patch. And then maybe they should stay at home and not go out because it would be a good idea not to wear a mask for a few days. So that's about masks. Now, what about moisturizers and skin cream? So I have, after so many years as an ophthalmologist, 30, 35 years, I realized that some patients have not been instructed adequately, and they have been using skin cream, moisturizers to keep their skin beautiful and moisturized. The problem is with some of these cream, they are so slippery that you cannot put the drape on, it doesn't stick properly. It might stick partially and then come off. So here is an example. Look at this beautiful skin and you think it's lovely. But actually, if you see a situation like this, you should tell them, please, have you used skin cream? Can you go and wash your face with soap and water and thoroughly dry before we mark the eye and start phaco surgery? So the telltale signs of moisturizer usage, firstly, you can see the skin sheen, as I've indicated to you. And the other thing is, now in the UK, we do mark the eye to be done. So when you put the marker pen on and you find that the ink doesn't stick and it just slides, you know that's another telltale sign. And finally, if you've missed that, when you're trying to prep the eye with povidone iodine, again, it washes off like water off a duck's back, you know you're in trouble. So what you do is, of course, patient education, very important. The earlier the recognition, the better, and just wash off with soap and water. Because by the time they've come to the operating theater and you send them away to wash, then you're wasting operating theater time. But it is still better to tell them to wash off and maybe do the next patient first before they come back. So those are some little things that I wanted to share with you during the pandemic. And I thank you for your time, and here are my email addresses if you wish to discuss anything with me. Thank you very much, Chairman.
Thank you, sir. Excellent presentation, and on behalf of All India Ophthalmic Society and the Chief Scientific Committee advisors, we would like to thank you profusely for participating in our conference and giving this wonderful keynote address, sir.
Thank you, sir.
Yeah. So, so we now move on to our next speaker, Dr. Paul. You're ready, sir?
Yes. Is my...
Oh,
well, this looks dangerous.
Yes,
well, you told me to, bear myself. Before I bear myself, well, everybody knows I am a reasonably good surgeon, but you don't know that after phacoemulsification, I become a bit trigger hungry. So this is what misfired shots that I have. Most of my surgeries there. Now, this is one case. See, I am a trigger hungry. I want to just put the lens, and look what I've done. This was the first lens of Rayner hydrophobic lens I was using, and there it is. And after that, I must have used only one of them. See there, I put the lens in the bag. Somehow I was lucky, but then there was a PCR. But thankfully, that lens stayed on, and you can see the rupture there. You can see. And look at this. This is a similar lens that I put in. I thought the lens is there in place, but after 1 month, I see the lens is slowly sliding. Actually, I had not put it in the bag. It was a small pupil, so I was in a hurry to finish off the case. I didn't check it whether it has gone in the bag, but gradually it slided. So later on, I just had to go and put it back. in the back. Well, this is one more misfire. Look at this. I go and then look at this. The lens has got stuck, and they're stuck. I'm trying to take it. I'm in a hurry. Let's see. There, the lens. I'm trying to take it out and see the lens haptic has gone. And hearing from Dr. Amar, I've seen his conference. I didn't have a PCR, so I thought that let me use this scaffold technique. Try this scaffold technique here before I, master myself. So there I put the lens there. So I explained myself that I want to cut the lens, so I needed to protect the posterior capsule, and that is how I just took out the lens, made myself happy. There, the lens is there in place. So another misfire. Now, what is this misfire? There, I'm putting the lens, and look at this. I'm not aware, and the lens is going to the area of my friend Dr. Rupak was there. So I thought, no, I can't share the booty with him. So let me take the lens out. Let me not give it to him, his area. So there I rotate it, reposition it, get it on over the lens and there over the iris, and then rotate it, put it on the sulcus, round it, and then the other haptic also goes in the sulcus. And my day was saved because I went for IOL capture, and that is it. But end of the day, the lens was well placed nicely. But look at this. This is again similar crime I had committed. I thought that I put the lens, and there the lens was halfway in the vitreous. And this time this patient came to me a month later, and it was already fibrous. Look at this. So I just tried to get it, and the other haptic was there. It is stuck. So again, I go in the similar way, try to rotate it, get it in anterior chamber, reposition it on the anterior chamber, and then I wanted to look for that area where I'll put that the gap between the anterior capsule and the iris, but it was already stuck there. So I wanted to separate it, and then this area I couldn't separate. I just had to use an MVR blade to separate the iris from the anterior capsule. And once I've done that, I rotate it, then again in the same way, put it over this sulcus and there, and then going for the IOL capture. The lens is there, and look at this. What is this? Suddenly this patient comes to me after 7 years after surgery. I see 2 lenses. When did I put 2 lenses? Actually, that was a history of trauma, and the lens had gone down and it was dislocated, and it had left an impression. The lens was there for 10 years in those lenses. So once my VR surgeon friend got it out in anterior chamber, gave it to me, I just had to just take it out and put the multi-piece lens. That's the best thing, because I had already opened the, I thought that I might need to do a SF-IOL. So the multi-piece lens goes in the sulcus. And then I need to just capture it and keep it. But this is a repeat misfire. Again, look at this. The lens goes like a missile. Yes, there it is. A missile, and I didn't know what has happened. It looked like there was a PCR there. Is there a PCR? I can see a lot of folds, a lot of broken capsule. And over it, I thought, okay, I'll escape. That part is still there. Let me dial this lens and put it in the bag. Those capsular rupture, whatever it is, somehow the lens will do, because I didn't have a second lens also. Once I put the lens inside and put this one, and then I realized, well, come on, where is the rupture? I don't see the rupture. What happened? What had happened? When I put visco there, everything looked okay, fine. Then why this folds and rupture there? And then I realized actually I had, the zonule had given up, and that had folded on, and that come there. So now what do? I just rotate it. I thought that I can put the haptic there, and then I put the CTR there. The CTR goes in the bag. There in the second hand, I try to direct it. Once the CTR is there, then I see, yes, there are a little bit of vitreous that are popping out. So all I need to do is put a bit of triamcinolone, do a vitrectomy, and take those vitreous that is there out. Once that is done, the lens is well centered, nice. Continue the vitrectomy round pupil, and that has made my day. But this is something which has really gone haywire. Look at this. This was a femto, uneven full femto. I had done it, and once I've done that, I'm going for I am there, I catch hold of the posterior capsule, and this was a eye-hands lens, one of those early lenses that somehow I put a visco plug, put the lens there immediately. Well, this was done, absolutely done, well-centered lens. I had no problem. I just pulled pilocarpine, end of the surgery. Patient goes back to the bed, and then suddenly I realized, what have I done? Instead of putting a 26 diopter, I put in 16 diopter lens because there was the earlier patient that was waiting. So the people already get it back, and we said that, well, we have to do some procedure again, something is left. So again, this pilocarponize, put in adrenaline, put in visco, and then so again, with the help of visco, and I thought that I should try the IOL scaffold. I thought, no, I can't try this, too much of things. So I just cut the lens, took it out, put again visco there, put the lens, there the lens goes in, well in the bag. So all is well, that ends well, and it was a great thing to bear myself in front of it. It's a trigger happy phaco surgeons who would like to, at the first instance, put the lens without thinking like me. Thank you, Shurja.
Thank you, Dr. Paul, and excellent videos as usual. It takes a great surgeon to do these surgeries, and even a greater surgeon to bear them in front of an international conference and audience. So I would like to call on our next speaker, Dr. Sumit Chaudhary. Are you there? You're ready? Can you start now, or you want to wait? No, you have to unmute first.
Thank you, Shurjo, for giving me a chance, and to AI for giving me a platform to speak from this dais. Bear to dare, yes.
Not bear to dare, dare to bear.
Yes, that's a thing. Always upside down mind. So this is the thing. This is a surgery of a 3-year-old congenital glaucoma, and you know the congenital glaucoma, always the medical therapy does not work. This is a temporary one, and the surgery is the goal of the treatment. But it's a little difficult situation when we go for the pediatric surgery than that of the adult surgery. Adults are more, I think it's easy to do and less complications are there, but the pediatric surgery, the eye has the sclera rigidity is very less, and eyeball is little bigger than that of the socket. Lots of pressure inside the eye, and also we need a very good anesthesia for the backup. But if we don't have this, we may end up to this type of complication what I faced. This is a conjunctival. You can see the length of the eye because the limbus is already in the back. The surgical limbus is a big eye. The small socket is large eye. I've just cut the conjunctiva. Tennis cut. The wet field cautery is being done here. And the triangular scleral flap is made. Again, the flap has to be very careful because it's very thin. And with the mitomycin C soaked sponges given for better result, because this is a large eye with only trap with won't work. This irrigation band. Chenectomy is all being done because they have the lots of thin tenons. So slowly I am moving forward for the partial dissection of the sclera. I want to go for the trab and trab. Ounce trabeculature one side is done, smooth, no problem. Other side again done, smooth problem. I'm very happy, everything going as per schedule. So that's it's being tried. This time what I did mistake, I didn't lose the speculum and I didn't ask the anesthesia to go for the hyperventilation. So you can see the iris popped up. So I'm trying my best to put the iris inside. Slowly I'm loosening all the superior rectus girdle suture. Suddenly something going wrong. I think the eye is getting tight. So I thought let's do some paracentesis left side port. so the eye gets softened. Try to give some pilocarpine or visco. The problem. Vitreous came out. There was zonular dehiscence, and you can see lots of vitreous coming out. This is a nightmare. What to do? Now the tension comes. So I did with the Vaness scissor, just to do the vitrectomy. Okay, then last the side port. Try to put the iris back. But it is not coming so far. So again, so I thought, let's see something else. So I started with the vitrectomy cutter. I did a vitrectomy. So far as I can, I tried to keep my cool head. This is a very tension time because I don't know, because with this vitreous, many things may happen. I did a vitrectomy. Someone I was putting the iris back. Oh, now the high fever started. That's another complication I have made. The high fever started. The blood is started oozing out. So I want to clear one thing, another complication starts. So I did the vitrectomy again, as much as possible towards the area, the internal ostium area. Somehow or other, I found the vitreous is less, so I go for the stitch. Let's see what happens. I'll see it later. At least I have to stitch it down to avoid lots of bad complication in these such cases. So I gave a one stitch of the sclera, the topical, and close the conjunctiva. Some of the now the eye seems to be quite quiet because anesthesia is also started giving the hyperventilation. They see the eye has quietened down. So I thought better to remove the eye film and the blood clots, whatever in the anterior chamber. Slowly I was taking it out. Yes, it's coming. It looks much better now. I'm much somewhat getting relieved. So this is end of the surgery. Now I can feel it better. I guess a visco in the anterior chamber. You can see the eye. This seems to be quite quiet with the bleb formation also there. And now it's some other relieved. I can at least sleep for that. This is the post-operative USG. Just a vitreous, some opacities are there. Not much detachment is not there. But I am still in the cross finger because I don't know what will happen. This is a post-operative 5 weeks period with the bleb. And this, but still I am in the cross finger. The patient came to me at least after 2 years. The patient is being followed, no more detachment still now. But I don't know what will happen to the next future because the eye is quiet, the pressure is lower. The patient can see till death. That's it.
Excellent presentation, excellent video. Sumita, really nothing you could have done actually in this situation.
No,
and
anyone can say like, something special can be done. I don't know.
not
That time I had this video. That's what the idea. Because in these types of cases, when I am the single surgeon, I'm in the OT, there are different opinion. If there are different opinions will be there, that will be much better for me. But that time there are no one.
No, even if there are 50 more surgeons in the OT with you right at that moment, nothing else could have been done. That vitreous couldn't have, nobody could have pushed that vitreous back into the eye when it popped out first between the iris and the trabecular flap. Anyway, excellent, sir. Thank you for being a part of this IC. We move on to our next presenter, Dr. Rupak Biswas. He needs no introduction. Busy surgeon. As you can see, we had to get him out of the OT for this presentation itself. He's still wearing his scrubs. So, Rupak,
can you hear me?
Yes, we can hear you. You can start your presentation anytime.
Okay, so this is the national race, I believe, right now for all the doctors. Not that you are not necessarily that you have to be in OT. So as Surya is trying to prove that he has targeted these 5 surgeons in India, that he will prove us that they are the worst surgeon, unless until he will not stop. So we are not getting so much of cases as of now. So what to do? So then we thought, okay, whatever is there in our old stock, then we start digging up there. There are life sometimes, when you start thinking that yes, if I get a different chance to again revert back of whatever you have done. So probably that is the. So I thought God give me another chance, and so this is a situation when give me some sunshine, give me some rain, give me another chance. So this is a standard vitrectomy process in a macular hole surgery. So you have started initially, is a relatively young boy. So here they have a little sticky vitreous. So you have started digging after doing the core vitrectomy. So we have given triamcinolone and to stain the posterior cortex. And we are just trying to separate the posterior cortex from the retina. And during this process, you become little jittery that you are not able to do it properly. So you just again took a second chance. And then no, it is not being happening. So you took a 4th chance. In the meantime, our OT assistant, they have put some water over here, and yes, you could do it. You could do the PVD induction. You are very happy, but yeah. Then once you remove it and then see, you have created a large retinal tear during your last attempt, and you become jittery of not happening things. So you try to use your force little more, and then you were stuck. So this is we had to do a laser surrounding that area, which is actually not was not a very good day for that day. But yes, a simple macular hole surgery can lead to that kind of situation. This is another when you have a IOL drop in the vitreous cavity and you have started doing vitrectomy. You are relaxed that okay, I'll finish the vitrectomy and then I'll simply just take out this lens, and this is a 3-piece lens with scleral fixation. I'll just take the haptic out and then fix it into the tuck it into the sclera. So I'm very happy that okay, I'll finish it off this surgery as early as possible, and because that was a long day and just trying to finish, and then this thing happens. So here you can see it here. You have touched your retina, and instead of finish it off little early, you end up of having a lot of other complications. You have created a full thickness retinal break, then you have to do that laser fluid air exchange of supporting that retina, and even after that also this is the lower part of the retina, so you are scared that after some time whether this patient will develop. So when you have a life out of control, so we can put can you enjoy the music?
Yeah, the music is fine. Okay, we thought we lost the video.
So when this situation comes, then you just try to reverse it off. So what was actually you did wrong? In the first case, you had jittery that it is not happening, and then you try to do it little forcefully. You end up of having. Second one is a relaxed. I need to finish the case at the earliest possibility, and then you are in soup. So even the simplest, the take-home message is that even the simplest case also you cannot be relaxed when you are on chair. So like how to proceed about it. So if you are not able to with the sticky vitreous, or you have a vitreous, having a vitreomacular traction, when you don't want to create a separate traction on the retina, especially on the vitreous during the macular area. So in this situation, we just try to clear the vitreous. This is the vitreous adhesion is more on the disc area and macular area. So what you need to do is you just try to separate from the disc area and the macular area separately. So there are two islands of vitreous sitting now. And then once it is separated, those areas you just trim it, and at the end, this part you can do it very smoothly and separately, so that there is no extra traction on the different part of the on different part of it. Thank you, Shurjo, for giving me this opportunity once again. But I promise you, I will keep on doing this kind of.
Thank you, Rupak. Excellent
surgeries, and I'll show it to you.
Thank you, Rupak. Excellent videos. And I would like to again give a disclaimer that I have not taken on these my co-instructors to defame them. I just have taken, I want to show that these are the people whom I send to manage all my complications. For cataract, I send to Dr. Paul. For refractive, Dr. Agarwal. For glaucoma, Dr. Chaudhary, and so on and so forth. So this is how they manage my complications. God knows what they're doing with their own. So anyway, but thanks a lot. And our next speaker is Dr. Shantanu Mitra. He's going to give us an oculoplastic ordeal for the complications he has created in his oculoplastic practice. Dr. Mitra, you're ready.
Is my screen visible?
Yes, your screen is visible.
Yeah. Thank you, Dr. Gupta, for including me in your most successfully running horror series, Dare to Bear. Which season is it? 10, 12? I think it's been more than that. Anyway, so in oculoplasty, we actually are more accustomed to get aftershocks. So this kind of aftershocks really give us the most trouble. So I'll be telling you the story of a series of aftershocks I got in quite a few number of cases, and this is still running on. This is the case 1 in the series, a male child, 15 years, with having a simple swelling in the right upper lid for 2 years, no other abnormality. On everting the lid, there was a cystic appearance of the swelling. So the surgeon decides to go for a surgical excision through a skin approach under general anesthesia. But after the surgery, in post-operative period, 10-day post-op, it was found that there is some amount of the cyst is still remaining, and he is having a complete ptosis of that eye. So patient and patient party was much aggrieved. So then we planned for a residual cyst excision 2 months later, but his ptosis was still persisting. And then 7 months following the second surgery, we took him up for ptosis correction through LPS resection anastomosis. And thankfully, till date, he is doing fine. So when a second case with similar presentation came to us, male child, 28 years, 1 year duration of ptosis. There was a huge cystic swelling from the superior border of the tarsus, no other ocular abnormality. Then the wise surgeon I am, I thought that probably the skin approach was the culprit first time. We did injure the LPS aponeurosis somehow, and we thought a conjunctival approach will be a safer procedure. We did a conjunctival approach, did the excision of the cyst, and unfortunately, the same result post-operatively. It is near complete ptosis of the left eye, and this patient was so aggrieved that we lost him to follow. Both time the histopathology came out that is a benign cystic lesion with fibrous tissue. So where were we going wrong? So this is the anatomy of the lid, the levator aponeurosis getting inserted on the anterior surface of the tarsus, and we are getting the cyst somewhere here. On either through skin approach or through conjunctival approach, we are somehow damaging the whole of the levator aponeurosis. So which approach will be safer, the skin approach or the conjunctival approach? And if we get similar cases in future, which way to go? Or should we at all intervene in these cases? So as usual, we got a third case in the series, 38 years males with a 1 year swelling, mechanical ptosis with some hypertrophy of the left eye. And we did a CT scan this time. We get a huge orbital swelling. This is the finding of the CT scan. And there's a huge cystic swelling. So this time we try to find a safer approach. But before going to that, we got a similar case. Before operating the third case, we actually got the fourth case of the series, the same presentation, 42 years male, cystic upper tarsal swelling, 8 months, no other ocular abnormalities, CT scan showing an orbital swelling. So we tried to find a safer approach, that we are causing damage to the levator aponeurosis. So we thought that better we go through a skin approach, just like a ptosis surgery. We isolate the levator aponeurosis, we disinsert it from the tarsus, isolate it, hold it with stray sutures, and then do the excision of the cyst. And then accordingly, we shorten the levator aponeurosis, tighten it a bit, and fix it back to the anterior surface of the tarsus. So here we are trying to separate the orbital septum to get the levator aponeurosis free. So this is the White-Knowles ligament, the fibrous attachment on the where the levator aponeurosis changes to its muscular structure and changes direction also. So after we disinsert the levator from the tarsus, then we try to dissect the cyst, and we found that the cyst was quite adherent to the conjunctiva. There's a full thickness conjunctival hole, and it was also adherent to the, at the margin of the White-Knowles ligament, it was adherent to the levator. So after excision of the cyst, then we suture back the levator, we tighten it, resect a part of the levator aponeurosis, and then suture it back to the tarsus. On the table, we can titrate it according to the necessity, how much lid correction should be done. So it's just like the rest of the thing is just like ptosis surgery. We have we just fix the levator there and see how much we can elevate the lid in normal eye position, and any reinforced sutures needed, we can do that also to titrate the maximum of the levator aponeurosis. So on table, it seems that we achieved satisfactory lead position, and then enclose the skin. But unfortunately, 2 weeks post-op is the same frustrating result. Yet again, it's almost a near ptosis. So we have to wait and watch to see what comes out. But luckily, 2 months post-op, when the edema subsided, the lid comes almost to a normal position. There is no hypertrophy of the eye. There is good movement of the eye also. So it's a phase savior for the surgeon. And probably this gives us, this encouraging result gave us a more efficient skill. And in the fourth case of the series, we, even in the first post-op checkup, we found that the patient had no ptosis in the postoperative period. But these are the whole case series. But the puzzle continues that what approach should we do for this kind of excision?
or should we intervene at all in these cases? I didn't find any reference of a similar kind of complication in the literature search. Thank you, everybody. Thank you, Dr. Gupta, for giving me the opportunity. Over to you, Surya.
Thank you, Dr. Mitra. Excellent cases. Is it all your patients are male and that's why you had ptosis, or just because they were male you induced ptosis?
No.
Does this has any correlation with all your cases?
I think that will be more appropriate for a female. If I can induce ptosis for a female, she will be more ready for surgery, next surgery.
Yeah, I think it has got, your surgical technique has got something to do with the male levator, because all your cases were male and they all had ptosis. You never showed a single female. I'm pretty sure you have done multiple skin excisions in female upper lid. None of them had ptosis. So anyway, excellent presentation. Thank you, sir. And I'll go with the last presentation, my video. I'll just share screen if it's possible. Is my screen visible?
Yes, sir, visible.
Okay. So this video is basically, this is a hypermetropic eye, plus 30. You can see it's fairly hard cataract, female patient, and only after staining I realized the patient is a case of pseudo exfoliation, because I did not bother to dilate and see the case in the OPD outdoor. So anyway, Rexis went off well, case going fairly good. Hypermetropic hard cataract, nothing else can be done in this situation. Slow motion phaco. Go ahead with phaco emulsification. I use a fairly high setting and I use a very hard and sharp chopper. But it's a very rubbery cataract. You can see the cataract is very rubbery, go in multiple times. So now the iris starts to come out, because apparently elderly female patients are also being given tamsulosin, which I was not made aware of before surgery. So now the iris is coming out, hard cataract, hypermetropic eye, old patient under topical anesthesia. So, well, you can't stop in the middle of the surgery. I continue the surgery, and phaco emulsification was thankfully could be, completed fairly fast. So since the iris was coming out through the main port, I have decided never to take out my phaco probe ever again in this cataract patient till I have finished the use of the phaco probe. So I go into multiple injections of viscoelastic through the side port, because I know the moment I take out the phaco probe again, the iris is going to come out when I am going to inflate the anterior chamber. But you can see the phaco emulsification went off well, not much of a cortical matter in this eye. Small cortical cleaning could be done. I'm showing off my left hand, right hand skills by withdrawing the iris with the irrigating cannula so that I can visualize the capsular equator more. These are all showing off techniques. Hypermetric lens, plus 30 diopter, very stiff, very hard lens, very difficult to fold. And in spite of repeatedly telling my assistant to keep the lens over the incubator, the lens was very cold also. Anyway, implanting the lens, 3-piece, multi-piece lens. I use a rotatory injector, and this is my normal technique. I usually implant the lens with the leading haptic inside the bag and then I dial the rest in. But in this case, the leading haptic had a very vague angulation to it. It didn't go inside the bag. Instead, it stayed in the anterior chamber itself. I was wondering why this was. I tried to, dip the lens back inside the bag, and again, it simply wouldn't go. It wouldn't go in because the haptic had broken off. It had not come out. It had broken off from the junction. So I have a topical anesthesia, elderly female patient with a broken haptic in a hypermetropic eye. Anyway, nothing that bad, can be handled. Take the haptic out, just make sure that the haptic doesn't get behind the lens and iris and gets lost in the sulcus somewhere. That's my primary concern now in this situation. So I try to, push the posterior capsule and the lens back as much as possible and try to push the torn haptic as much possible anteriorly so that I don't lose it. Right now, the wound size is the least of my concerns. So I enlarge my wound size. and I don't have a microfaucet. When this surgery was done, I didn't have a microfaucet, so I go in with a simple McPherson, but the haptic simply wouldn't come. But after much trial and tribulation, I could bring the haptic out. So at this stage, nothing else can be done because the haptic is broken. It didn't come out. So I decided to cut the lens, take it out and replace the lens. Now, when I'm cutting this lens, this is a very thick lens. You have to realize this is a plus 30 diopter lens. Iris is coming out, and I have taken and broken off the other haptic also. So now at this point, I realized something was defective with the very lens itself, because the haptics were so soft that both the haptics broke off when I was doing the surgery. So now I have a 30 diopter disc in the anterior chamber in an 80-year-old patient with iris coming out under topical anesthesia. What to do? In this situation, I decided that it's better I use what is called an IOL scaffold. So thankfully, all these odd diopters, I always keep a backup lens. I go in with a second 3-piece lens, inject it inside the bag. Make sure that this lens is in position. It doesn't have any broken haptics. Luckily, this didn't. So I dial in my leading haptic inside the bag now. So in this way, at least I'm safe. I have a lens in the bag. Now comes the challenge of taking out this hypermetropic lens. Now, what do? Do I enlarge the incision and take out the lens in toto? Or should I try and cut the lens? So I decide I try and cut the lens. But there's nothing supporting the lens. So whenever I'm trying to cut it, it flips. You see that? It's a thick lens, and so it flips. I have an extremely hard time cutting the lens because I'm not holding the lens with a lens holder from the other side. All these precious instruments are not available to me. I work in a very cheap and small setup. We have very basic instruments. So anyway, I could cut a part of the lens. Now comes the challenge of pulling it out. You can appreciate the phacodonesis of my forceps, that is the tension tremor which has already kicked in, because the topical patient is now shouting, iris is coming out, lens is not coming out. It's been almost half an hour into the surgery. By the skill of editing, I have brought this video down. But by the grace of God, I could finally take the lens out. The iris finally decided to stay in the eye, and we could manage to keep the anterior chamber fairly stable, as you can see, by forming it with air. So this is the end of the surgery, but this is not the end of the torment. Believe me, as much as I would like to tell you that the case went very well. The patient has 6/5 vision the next day without glass. Patient had hand movement the next day. The cornea and the sclera were of the same color. Patient has gross congestion, lid edema. Patient was complaining, and for around 2.5-3 months, the patient couldn't see anything. So this is my nightmare, which I wanted to share with you all. And if any audience is there, I don't know if any audience is there in the hall. But so we have come to the end of this session, and I think we have finished a lot early, around half an hour early.
Yes.
The next session is supposed to start at 5:30, but do we have any? I don't know whether how can we take any question? No, there's no way we can take audience questions. So I thank my co-instructors again for allowing me to insult them year and year over and over again. Try to make as many complications as possible, and please don't feel bad. Although it might not be a learning curve for you or a stepping stone for you for every mistake you make, but at least you get the pleasure of presenting in my session every year.
We also hope that your series goes on.
Yeah, thank you, sir. And again, Dr. Liu, I would like to thank you on behalf of All India Society for gracing us with your presence. Although you have we can see you have a very busy morning clinic going on right now.
Not at all. It's been a pleasure to join you.
Yeah, thank you,
Take
sir.
care
and
and see you very, very soon. See you at the next meeting.
We'll see you, sir. Thank you. And I would thanks to all the
Bye.
participants and the co-instructors. Bye.
Thank you, Surya.
Bye-bye.
You're giving us more tension than to produce. Again, one more year, I have to produce more complications.
Complication to come to you.
This year, we got something from our store, but with the corona time, with less patients, like Rupak had to go, I had to go back to my old, because this is a tough time. So you cannot, do complication. You have to do somehow. You're doing less cases. So
Yeah.
The bad cases now.
For some people, the complications comes naturally, like me. So I don't have to work very hard regarding this. But again, sir, thank you for bearing yourselves and showing us all your complications. Being the excellent surgeons you are, to show this really deserves a lot of credit. Thank you all.
Thank you,
all.
Sujo. Thank you, Sujo.
Bye.
Bye-bye.
Bye-bye. Bye-bye.
I would like to thank all the doctors and all the panelists of this session. Thank you so much for joining us here with us.